Thanks very much, and congratulations. It's the third time I've had the privilege of speaking at Dr. Hiranyakis' meeting, and I think it's the best one yet. Very well organized, different venue, no beach outside, but a really nice venue and highly well organized. So this last talk is focusing on something that we've been doing in the United States for the last 6 years, trying to build up a program for our rectal cancer standards as exists in Europe. And that's going to be the focus of the talk with a little bit of background first. And it may surprise some people because in many ways North American standards are held very high for roads, for airline industry, for construction, foods. A lot of things are held at a very high standard, but for some reason rectal cancer is not. Even thoracic surgery is. There's a database and you can look and see how your thoracic surgeon performs for mortality for coronary artery bypass surgery. But for rectal cancer, the care is really, really variable. Both the short-term care, like making colostomies, the surrogate oncologic care, like circumferential margins, distal margins, quality of TME, and number of nodes. And then, of course, the long-term, which is what really counts, such as survival. Well, when we look at Europe, you can see the difference in terms of rates of colostomy, and they do tend to be high. I mean, 25, 30, everyone, we go to these meetings and amongst ourselves talk about intersphincteric resections and coloanals and very few people getting APRs, but when you get out in the real world, in the district general hospital, in the UK and in the large government hospital in many countries, Germany and Italy and the like, there are still very high rates of permanent colostomy formation in patients, not terribly different than the US, where this the AHRQ database was queried, and it tended out to be 50%. Now, there may be some differences in surrogate quality, and if you look at overall margin rates, and then some papers break them down, low anterior and abdominal perineal resection, I've put across the board here, you've got the US data, which are ours, recently 17%, French, German, Dutch, Polish. The CRMs, except for the Germans and the French, tend to be in the vicinity of around 11 or 12%, higher than we might expect. And a lot of it's dependent upon volume. So when you look back, these facts have been known for years. These studies on this slide date back to Les Bouquet in Sydney, Australia in 1997, so 20 years ago, and he based those data on retrospective analysis from prior years. So over 20 years, we've known that volumes as well as training are related to morbidity, mortality, and recurrence. And the better trained and the higher the volume you do, the better you're going to be able to confer upon your patients a disease-free survival without local recurrence, without morbidity, without mortality. And that's been shown. I've put the flags up, so even if you can't read the numbers, you can see that around the world we've seen these same issues place after place after place where surgeon volume makes a big difference. Honing in at the University of Minnesota and some relatively recent data which really led this effort to come underway. So somewhere in the early 2000s, David Rothenberger was, or late 90s, early 2000s, David Rothenberger from the University of Minnesota was the president of the American Society of Colorectal Surgeons. And one of his efforts was to try to launch a national program where we could have an accreditation schema as exists in Europe and UK. And he didn't succeed, unfortunately, and probably for two reasons. One, he tried to drive it through the ASCRS, which probably was the wrong group, because there are other groups of surgeons who do very good work. Society for Surgery of the Alimentary Tract, Society for Surgical Oncology, American College of Surgeons, and others. That was one problem. The second problem was he tried from day one to involve ASCO, so the American Society for Clinical Oncology, as well as the radiation oncologists. And when you start having so many groups involved, as well as radiology and pathology and surgery, it's very difficult to find common ground, and it's just too big a group, too unwieldy, so nothing happened. But one thing that did come out of it was this subsequent paper from the Minnesota group looking at 41,000 patients who'd undergone a radical proctectomy, and you can see that firstly, most had colostomies, and this isn't these are not patients from Minnesota, but it's a study done through Minnesota. It's a national inpatient sample. The way this database works is they take 1 out of every 5 hospital discharges in the country, and they assume that that size sample, and statistically this is supposedly invalidated, they assume that that size sample is representative of the whole 100% cohort of patients who were discharged from U.S. hospitals in that time. So over the 5-year period of 1988 to 2003, 41,000 plus patients underwent a proctectomy for rectal cancer. 60% had colostomies. I mean, it's a staggering number. Only 40% had sphincter-sparing procedures. And this isn't this isn't Lisfranc and Cuthbert Dukes. I mean, it's relatively contemporaneous data, but it was a wake-up call for a lot of us that we definitely can do better. And in fact, the rate was flat after 99. So it's not like you could say, oh, well, 99, and things kept getting better. They didn't. We weren't getting better at doing it. There were also certain things that predicted colostomy: low-income zip codes, low-income people, elderly people. The bottom line is most radical resections for rectal cancer in U.S. hospital at that time resulted in a colostomy. So others looked at the same issue. Rocco Riccardi from the Leahy Clinic looked at this, and he looked at discharge data from 21 states in the U.S., looking at county level. So we have 50 United States, and within each state are a variety of counties. So the smaller units are the counties. And if you look at this map here, you'll see a state, for example, and within the state it's broken up into lots of different little counties, and they're all color-coded. So if you look at the overall map, you have California here, and Washington, Florida, and New York, and the Carolinas and the like. And within each of those are counties. So what Riccardi did is he looked at 20,000 proctectomies performed kind of at the tail end of the Rothenberger study, 2002 to 2004, and found that, again, 50% of patients got an APR, not terribly different than the 60% in the Rothenberger study. But what was perhaps even more surprising was only 20% of counties in the U.S. had colostomy rates less than 40%. So either patients in these counties were somehow only having tumors invading their anal sphincters, unresponsive to neoadjuvant therapy, or patients were just getting APRs because surgeons either couldn't be bothered or weren't skilled or were concerned, whatever the reason was, to do a restorative resection. So colostomies became automatically something that people could latch on to. We're doing too many colostomies, forgetting all the other granular details of circumferential margins and local recurrence and sexual function. Too many colostomies to begin with. Why? Well, again, to turn to Riccardi and his colleagues in the Leahy Clinic, perhaps it had to do, as we showed in the earlier slide, with who's performing proctectomy in the United States. So another type of study, same kind of time period, roughly 15 years ago, 11 states, hospital discharge data, over 7,500 proctectomies by 2,600 surgeons. So now this isn't county level, it's not national, by surgeons. 40% of surgeons performed only APR. So now you say to yourself, okay, so is it possible that 40% of surgeons only see patients whose tumors invade the anal sphincters and have to get APR? Again, it's possible, but probably not. More likely people either don't want to, can't be bothered, or concerned, aren't trained, whatever the case may be. And what was perhaps even more concerning is that the surgeons who did restorative procedures also were more likely to do other pelvic operations. So it intimates, it's a sort of surrogate marker that the people who do anterior sections are also doing pelvic pouches and other types of pelvic operations. And if you add to it the colostomy being bad enough, over and above colostomy, there's a higher mortality, double, in the patients who are undergoing surgery by these surgeons who only did colostomy. So a higher chance of dying, higher chance of having a permanent colostomy versus getting care in the hands of a specialist. So the saga continues. Again, so this is the same data set as the prior study, but now adding in tumor characteristics from the SEER database, Medicare, hospital characteristics from the American Hospital Association, surgeon specialty from the American Society of Colorectal Surgeons and from Society of Surgical Oncology. So now these are the same data, but adding a lot more fine-tuning to them. And the high stoma counties, which are 26% of all counties, defined as at least 60% of patients getting colostomies, mean of 71. That means you've only got a 1 in 3 chance of walking out of the hospital in one of those 26% of counties without a permanent colostomy. These same places were less likely to have an MRI scan, as we all just heard in the last panel we need, less likely to have a PET scan, less likely to be teaching hospital, fewer specialty surgeons, as shown here. So the people not only aren't even doing the right surgery, but they're not even attuned to what are the appropriate standards. How do we manage these patients? How do we evaluate them? How do we decide if they get neoadjuvant therapy? So looking at all of these problems, in 2011, at the prompting of Feza Remzi, I organized a group of people at the time, including David Dietz, who was at Cleveland Clinic then, Feza Remzi, who was at Cleveland Clinic then, John Monson, who'd just come across from the UK, from Hull, was working in Rochester, New York at the time, Jim Fleshman, who, along with me, had tried to work with David Rothenberger on this initial effort of the trial. We enlisted a couple of other people from Society for Surgical Oncology, from SAGES. We enlisted Mariana Barrow from College of American Pathology, and Mark Golub from Memorial Sloan Kettering, American College of Radiology, and Greg Del Prio from Baylor, Texas, American College of Radiology. So we did not include medical oncology, radiation oncology. We thought it would be better to start with the surgical treatment, not to go over all rectal cancer, just to start on the surgical treatment. We tried to take a wide swath of different institutions as we looked at it, diverse size, diverse geography. We included in our initial cadre of centers, and I think I have it listed here. So we have Rochester, New York, which is northeast, Mayo Clinic, large clinic out in Rochester. Everyone knows MD Anderson and Memorial. There's 2 cancer centers, one in Texas, one in New York. University, where Jim Fleshman was, WashU St. Louis, University of Minnesota, where Dave Rothenberger had done a lot of the initial work. Here's a small hospital, Boone Hospital. I'm sure most people can't tell where that is. I'm not even sure I can tell where it is, but it's in a suburban area somewhere near St. Louis, and that's okay. We needed those people involved. And we subsequently also drew in Sam Uman from John Muir Hospital in Walnut Creek, California, another small community hospital, but necessary. This is where patients get treated. And we took advantage of the expertise in MR synoptic reports as well as in statistics from the group from the University of Toronto with Richard Resnick and the like up there, Robin McLeod, Sandra de Montbrun, Helen McRae. Over time, as people found out we were doing this, we started with 11 groups. By the time we just met recently, it was over 350 groups that expressed interest in participating in this program. Why? Well, we put a lot of articles out in the literature explaining what the problem was. We published papers. This one was Dave Dietz. He presented it at Society for Surgical of the Alimentary Tract, published it in Journal of GI Surgery, Failure of Evidence-Based Medicine. This one was John Monson, highlighting a lot of these points. Maher Abbas, and so on. So we've got a lot of these different studies here talking about it. This one's in JAMA Surgery, Annals of Surgery, one of our current residents. This is the one that found the 17% CRM positivity rate, and so on. So what the proposal was from this group we called Ostrich was to create a system like in the UK and in the EU where we could have standards which allowed at least to set the stage for things to be done the right way. The actual results would follow, presumably, because the assumption in any program is if you implement the steps and follow them, things should go well. However, the Ostrich isn't the group to create the implementation. The group is the American College of Surgeons. Why? The American College of Surgeons has been around since something like 1913, so about 100 years. The very first program that the ACS created was JACO, Joint Commission for Accreditation of Healthcare Organizations. Many of you have JACO International accreditation for your hospitals. That was an American College of Surgeons initiative, was the first. But it was too cumbersome, too time-consuming, and they divested. And we still maintain a major leadership role within JACO from our Board of Regents. But the second program was the cancer program. In 1922, the Commission on Cancer was established to improve the standards of cancer care throughout the United States. And you're probably familiar with many others. NISQIP, you can't open a surgical journal without reading a NISQIP article. MBSA-QIP for the bariatrics, the Committee on Trauma, NABPC for breast. These programs work. If you look at the NABPC data, and these are some pretty new data from this year, 2017, using one of the NABPC quality measures, that post-mastectomy patients with 4 or more nodes should receive radiation therapy, post-mastectomy radiotherapy. So the point of the article, the study, was to look and see how often NABPC accreditation affected compliance with this quality measure. One simple question based upon the structure of the program. So women who underwent mastectomy either at an NABPC accredited center or a COC accredited hospital, but not NABPC. Now, the rectal cancer program is different because you cannot be a COC accredited national accreditation program for rectal cancer unless you're COC accredited as a cancer center. Breast, that's not true. You can be accredited just as a breast center and not COC. So they compared these groups of patients, and what they found is that NABPC centers yielded a higher rate of appropriate post-mastectomy radiotherapy than did COC hospitals without breast expertise. Statistically significant. Moreover, when centers had an audit coming they had their accreditation, they started to do better because they looked at their data, and it's like anything else. Once you start looking at it, you see what the issues are, and you make it better. So the program of accreditation works. It makes things go forward the way they should. So in 2014, May 2014, I brought 3 years of our work to the Commission on Cancer and then to the Board of Regents of the ACS. And I mentioned this already. The COC is responsible for accrediting 1,500 hospitals in the U.S. at which about 70% of recently diagnosed cancer patients are treated. They're committed to providing comprehensive, high-quality, multidisciplinary care. Multidisciplinary came in 1922, way before all the things we're talking about now. The COC sets standards, looks towards also prevention, research, education, and monitoring. Who makes up the COC? There's 56 member organizations. They're not all surgical and they're not all medical. It includes tumor registrars. It includes geneticists. It includes the American Cancer Society as a lay organization. It includes the Susan B. Komen Foundation, which is breast cancer, not physicians. It includes the Lance Armstrong Foundation, and so on. So it's a wide swath of people with a lot of full-time staff, about 100 staff plus different committees, set to establish these standards and then to follow the standards. And the way you know if the standards are being met, obviously, like any standard, is to collect the data and look at treatment patterns, look at outcomes to ensure that things are being done by best practice, help people achieve those goals through education, early detection, and care delivery. The benefits to the program, and therefore to the patient, are a commitment to high-quality care, in part because resources are dedicated to help provide that care. Now, as an added bonus, all of the data from every COC program go into the National Cancer Database. National Cancer Database is vast. The National Cancer Database looks at treatment and outcomes from all 1,500 COC accredited programs. Over 1 million new cancers a year are entered. Currently, there's almost 30 million cases. It's the largest cancer database in the world as far as we know. Represents about 70% of all cancers, jointly supported by COC and ACS. So if you're participating in the National Accreditation Program for Rectal Cancer, your data will be housed in the NCDB, and you can mine data back and see how you do, which is part of continuous quality improvement. And this is a much newer program. It's 1989. But it's a much newer program. So using some of our NCDB data, there were 22,000 patients in it that year, about half of the annual rectal cancers, 1,327 facilities. About 90% of COC hospitals were operating on rectal cancer. The range operated was one per year to 286. So a huge variance. The median number was 27. And this is something to think about as we look at our standards. The standards are different types of measures. Accountability. Accountability are based on randomized clinical trials considered high standard of care. For example, that you should perform a TME. This for us would be something, you know, that is irrefutable. Quality improvement measures based on retrospective data or based on consensus, but not necessarily on a randomized trial, and these things should improve over time. And this one might be capturing tumor regression grade, for example, or looking at EMVI on an MRI for the moment, you know, and that'll change as we get more randomized controlled trials. And then there's surveillance measures where we're not quite sure what to do with it, and it's for quality improvement. That might be something like the rate of abdominal perineal resection, as long as it's in relation to the height of the tumor. So what is the program itself? The standards, as they follow, the first one is that the program, as I mentioned, has to be COC accredited. There is no way you can be NAPRC accredited without being COC accredited. Number two, it has to have a multidisciplinary rectal cancer team with a minimum of one physician from each of these specialties. Now, these standards are under some slight tweaking and evolution, should be finished by the American College of Surgeons meeting October 20th to 26th in San Diego, but where we stand now, certain things will not change. This will not change. You have to be COC accredited, you've got to have surgery pathology, radiology, medical oncology, and radiation oncology. All surgeons who perform rectal cancer surgery, as well as all radiologists who interpret imaging, MR imaging, and all pathologists who read should be members of the team. This one may change a little bit in that not everyone can get to 50%, and we're looking at some variations here, possibly that there is a representative from each of the specialties per meeting so that individuals aren't held to 50%. We're looking at that. This one's very, very important. You must look at cases real time. The point of this program, and the only way it works, we know this from the UK, is not that you retrospectively go back and say, oh yeah, that patient's now in the midst of neoadjuvant therapy and we've set a surgery date. No, the point is, the patient came in the door, we got an MRI, we have a tissue biopsy, we got the chest, abdomen, pelvis CT, we got the CEA, they had the colonoscopy. Now what are we going to do with them? Well, you can't wait. So if you're at a high-volume center, you meet weekly. In Cleveland, Ohio, they're now meeting twice weekly. We're meeting once weekly. Every other week might suffice in some places, but we put on 8 to 10 to 12 cases per week, and that's, you know, that's a fair number of rectal cancers that we see every week. There's a director, so not a full-time job, obviously, but one person has to be responsible as the physician liaison who takes care of rectal cancer to make sure all of this is happening. And then there's a program director who also doesn't have to be full-time, but certainly could be full-time, because this person's job is ensuring that everything happens on schedule, that the MRI is done, that the outside path slides are reviewed, that the patient begins their neoadjuvant within a certain time period, that after surgery they get adjuvant within a certain time period, and so on. There's a lot of things that have to be reported, and that's what the director looks at. Outside path report, staging before definitive treatment, full staging, chest, abdomen, pelvis CT, PET scan's optional, rectal ultrasound's optional, MRI is not optional. Standardized staging, synoptic report, not just any report. CEA, at the end of this conference, the MDT will issue a treatment evaluation and recommendation summary, which goes to the referring physician, and if the patient wants it, also to the patient. After treatment, we look at the pathology specimens. We look at the grosses, as Dr. Sands showed, and we look at the bread loaf, and we compare if there's any discrepancy between the pre-op MRI and the post-op bread loaf. We look together and say, what did we get wrong? Why did we think this was EMVI and it wasn't? Why did we think this was T3 and it was T2? So standardized operative reports for pathology as well, and then another letter to the referring physician, and if the patient desires, to the patient, saying what happened during surgery, what are the next steps for treatment, for follow-up, and so on. There's training courses being established. So these are really more educational modules, more than training per se, but there's a surgical one that Connor Delaney is developing, a pathology one, which Mariana Barrows completed, and an American College of Radiology one, which again, Greg Del Prio from Texas and Mark Golub from New York are working very heavily with a woman named Judith Yee, who's the administrative person at American College of Radiology and the American Society for Abdominal Imaging, so that every one of the groups will have access to educational materials and a self-assessment test. Certain things are immutable. You have to be sure you're operating on cancer. You can't just take the patient's word for it. You've got to have some backup that it's cancer, and you've got to stage them. Now, the MRI, as we said, has to use a protocol that looks at every single one of these things, because it's really important to know the depth of penetration, the status of the CRM, lymph node involvement, extramural, and so on. The radiologist has to use a synoptic report, and we've taken this one, which again, is a variety of the Gina Brown report, which went from Gina Brown to the University of Toronto to most of the rest of us, and it looks at these things in terms of all of those variables: the mesorectal fascia, the depth of invasion, relation to adjacent organs, lymph nodes. If the patient has somehow been treated before they show up, tumor regression might be included, certainly EMVI would be included. These are all very important things, and it's all public domain online. CEA, before and after treatment, and we have the planning discussion. Here's a template we use at Cleveland Clinic, Florida, to make it very quick and very easy. We don't go into a long social history on the patient. We don't describe all their medications. We do the nuts and bolts of where's the tumor and what are the things required by the MDT for the National Accreditation Program for Rectal Cancer. What do they show? And that's all we're going to put here. And then we fill it in as we go through the conference. So as that patient's presentation is finished, the fellow or the resident has typed in essentially what goes in this treatment evaluation summary, and then a letter gets generated that the staff previews and sends. And optionally, we can put in colon or anal cancers, but this conference is meant for rectal, and the letters get sent out for rectal cancer, and we tell people what we expect. And here's an example. Here's one for Dr. Sands, just to show your patient was discussed, the path staging was such, here's what was recommended. It's just a template of a letter. There are timelines, and this is part of what the treatment coordinator looks at: 60 days. The synoptic operative report is interesting because we require the pathologist to use a synoptic report. We require the radiologist to use a synoptic report. Why not us? So we're actually looking at creating a synoptic report, and a lady named Arden Morris from out at Stanford is working with others on creating for the EPIC and for Cerna, the other major electronic medical record, these synoptic reports through the Quality and Safety Assessment Committee of the American Society of Colorectal Surgeons. And I'm not going to click on the link, but it's an interesting operative report. It's pretty quick and easy to use. You can put some narrative after if you like. The pathology report is synoptic. It's been for many, many years from the College of American Pathology, and it says all the things that we want to know about it: the radial margin, the distal margin, the quality of the TME, vascular invasion, perineural invasion, and so on. It's all listed there so you won't forget anything on the synoptic report. The photographs are key. Surgeons are competitive. I mean, nobody got to be a surgeon, finished all your undergraduate studies in med school and going into residency and fellowship if you're not in some way competitive. And the last thing you want to see is your specimen up on a screen like this with all your colleagues in your hospital, and instead of a gorgeous specimen like Dr. Sands showed us that she takes out all the time, that it looks like the next door neighbor's dog had a bite out of it, and you see bare muscle. You don't want to see that. And our pathologists will show us the gross specimen and then the bread loaf specimen, and when there's any doubt about where this mesorectal fascia, if there's maybe this one is near complete, maybe this isn't complete. It's not incomplete because it's not to muscularis, but it may be near complete. And then we'd compare the depth of invasion of the tumor to what we see, for example, on the MRI where necessary. Based on all of that information, we make a decision for adjuvant therapy. That decision again gets communicated in writing. These are the elements that are put in so that the referring physician, and if the patient desires, the patient knows what's going on. And we again have the program coordinator track down the timing. The quality improvement variables are there as well, and as I mentioned, those are going to be more accountability and surveillance measures because we don't quite know what to do with them, and there are extraneous factors that enter into things like APR. It may be quite appropriate if the tumor is invading the anal sphincters. You may happen to have a high rate, but it has to be in relation to the dentate line or the anal verge or the sphincters. So these are all things that we're going to be tracking. Pilot surveys were done last year at these 6 places, and the program should roll out in October through the American College of Surgeons Commission on Cancer. So by the time everybody's over visiting us in February for our annual international symposium, this program should already be launched in North America. It's been 6 years, almost 7. In real terms, and since Dave Rothenberger's vision, it's been about 12, but we are finally getting somewhere. So I'd like to thank everybody for their time.
Thank you, Professor Stephen Wexner.